My name is Sarah Busi. I am an internal medicine resident. Today, I'm presenting a case titled Plasma Cell Dyscrasia Presenting as Cardiac Amyloidosis. This case highlights the importance of maintaining a high index of suspicion for cardiac amyloidosis, particularly when systemic findings coexist with unexplained heart failure features. Our patient is a 65-year-old woman with hypertension, presented with 4 months of progressive dyspnea, palpitations, and fatigue. This patient clinically appeared volume overloaded. While her symptoms were nonspecific, initial evaluation suggested a process extending beyond isolated cardiac disease. Her laboratory evaluation revealed normocytic anemia, profound hypoalbuminemia, and nephrotic range proteinuria, raising concerns for systemic involvement. Cardiac biomarkers were elevated, supporting cardiac involvement. Together, these findings suggested a multi-system process rather than a primary heart failure alone. Electrocardiography demonstrated low-voltage QRS complexes. Transthoracic echocardiography demonstrated increased left ventricular wall thickness with a small cavity size, diastolic dysfunction, and preserved ejection fraction. Global longitudinal strain analysis revealed relative apical sparing on the bullseye plots, cherry on top pattern, which is suggestive of cardiac amyloidosis. Tissue Doppler measurements were consistent with high filling pressure and impaired relaxation, which were seen in infiltrative cardiomyopathy. Given these echocardiographic findings, cardiac amyloidosis was strongly suspected. Advanced cardiac imaging with MRI demonstrated patchy late gadolinium enhancement involving the basal to mid-septum and inferolateral walls, reinforcing the presence of infiltrative cardiomyopathy. Hematologic evaluation revealed a monoclonal IgA lambda gammopathy with an abnormal 3 light chain ratio. Multiple myeloma was diagnosed via bone marrow biopsy. When integrated with preserved ejection fraction, low voltage ECG, and apical sparing on strain imaging, these findings supported AL amyloidosis as the unifying diagnosis, prompting tissue confirmation as accurate subtype to distinguish AL from transthyretin amyloidosis is crucial to guide therapy. Endomyocardial biopsy provided definitive diagnosis. On hematoxylin and eosine trichrome staining, amorphous extracellular deposits were identified. Congo red staining demonstrated apple green birefringence under polarized light, confirming amyloid deposition. Liquid chromatography tandem mass spectrometry subsequently identified AL lambda amyloidosis. Subsequently, our patient was treated with cyclophosphamide, bortezomib, dexamethasone, and daratumumab, achieving complete hematologic response with stable cardiac function at 12 months. In a nutshell, diagnosis of cardiac amyloidosis needs a deep clinical instinct and high suspicion, as it's always present as a wide array of systemic symptoms. Early diagnosis is the key for favorable outcome. Classification of amyloidosis is critical as a treatment for AL lambda cardiac amyloidosis is completely different from the transthyretin subtypes. Thank you.